All right, here is a little reiteration and emphasis on the language of nursing, how we have to think of it right now. Please remember not to get too far ahead of yourselves. All right, we are going to talk about the nursing process within which these nursing diagnoses are heavily used. However, this helps to lay the groundwork for how that's all going to fit into the nursing process. Because to try to present those two things together is really going to would really be cumbersome, and splitting it up too much makes it really confusing. So this is the best way to start presenting it. So we'll talk about how we looked back at past knowledge and how that is sort of related and what the rest of this topic means. So we're basically focusing on NANDA, NIC, and NOC, as sometimes they are known, right? But we're going to explain it in more detail so it gets a little bit clearer for you. So the first thing to think about is, how does this language of nursing really work? Where does it come from, and why do we need a language? Well, think back to what we said when we talked about nursing history and theory. Okay, nursing was defining itself over and over again up through the ages, and defining itself meant to have and provide and make sure we're working within a certain organized structure so that we could sort of guide care and really establish and then maintain all these great standards that achieve great outcomes. So the theory came into play by talking about four main components, and that language from the theory helps define the nursing care from those four perspectives, okay, which we're going to talk about then. And then the language from NANDA sort of uses critical thinking in a form of nursing knowledge and judgment to enact and define nursing actions that come under the independent scope of practice, something you don't need a physician order for. And then there may be an ANDA diagnosis list is a certain list of words, and now there are some things that need to be addressed by nurses with their independent scope of practice that don't fall into the NANDA categories. So that's when we were talking about that quote, other category, end quote, that talked about, well, what happens if you have something that doesn't fit into it? You still need to address it, and at least, or start to address it, depending on collaborators need to be involved and all of that. So that should be clear now. Please remember that all of these things are in your text so that when you get lost, go back to the prep and the reading and use your learning style, because chapters 10 and 12 have most of this in. We're going to be delving more into this when we talk about nursing practice. And your book does have other nursing diagnoses addressed, but it kind of has them spread out through the book. So having a lecture like this is valuable for you because it kind of pulls it together and helps give us a starting point. So we're still sort of layering in the information, and it's not going to stop until we get to the end of the course, and then it will continue in other courses that you have. So if we go back to nursing theory, and it doesn't matter who we pick, we know that a nursing theory is including language that helps to define our practice. And it does that by looking at the four components or concepts that live within those theories. So that is patient, health, environment, and nurse. So we could say that from a patient perspective, that means patient-centered care and being very proactive and thinking preventatively for patient needs and recognizing them as part of critical thinking. And then we're going to eventually use clinical judgment to enact nursing actions. Okay. Health as it relates to the person overall, maintaining health at the optimal level that we possibly can. Environment may include, manipulating the environment when they're in a hospital setting to make it more soothing, more calm, or make sure it's clean, all of those things. If it's in the home, it may apply more to things like safety. And then the nurse, of course, is the person who's going to help take all of this and manage the care. So you will have, this does mandate you going back to review those theory pieces again. The little green blocks we talked about in Masters will help you to see what it is that you should be looking at and how you should be considering that. That will help bring this together and solidify it. Okay, now this, I really like the colors here. The language of nursing related to NANDA. Okay, remember, NANDA is nothing more than an approved list that says, if we go back to the structure, organization, even things like the helix, we have to be organized. So commonly occurring things that can happen to patients are what becomes a NANDA approved diagnosis. And the reason that list gets updated every so many years is because patients are always evolving, nursing care is always evolving, and different more common problems may surface that need to be included on the list. So the NANDA are organized by 13 domains, which we talked about and you have a worksheet for. They're used to plan and initiate the nursing interventions. They're actively used to achieve outcomes. And then they're going to mandate use of nursing knowledge and judgment. And this is the independent nursing scope of practice. So anything that's not from a doctor's order directly, but that you have to have a part in. So some of the examples we used was, even though you need a doctor's order to give a medication, it's a nursing intervention and responsibility to observe what's the patient's response and tolerance of the medication. Is the outcome achieved from whatever that medicine was prescribed for? So if it was Lasix and we know the medicine is used to pull fluid off a patient's system, are they passing enough water? Is their output sufficient for an 8-hour shift? Is their weight responding appropriately to that? And there will be more of those things that you learn as time goes on. The important thing is it's just tied to outcomes, and we want to be monitoring all of that. So the other example would be, let me think, giving a tube feeding. Yes, tube feeding is an order, but independent of that order, we need to think through, okay, you just don't hang the tube feeding through the nasogastric tube and never assess it. You need to assess placement and patency of the tube. You need to ensure that the orders are being followed, that the fluid is indeed infusing. If you have to stop and start it 20 times, well, not 20, but several times during the shift because the patient is vomiting around their tube, or, well, that's an extreme example. But having other problems that you would have to call the physician about, then they're not tolerating it and more actions would be needed. So it really does come down to not just the judgment and the knowledge, but how you use critical thinking, how we consider safety in every single action that we have, how we're setting priorities, and everything that's in those helix bars. So it really started from all of that back then. Okay, and then finally, those things that don't fit into NANDA formatting might be hardest to understand. But think of it this way, and in a day's time when you deal with your patient and you think about all of the things that might be happening with them, not everything is going to fit into a category because patients are so unique and very dynamic and different. So you just have to think about what types of things you might see that you would still need to do and initiate an action for. And it may be that action is just to talk to the physician and then the physician will order something else. Or it may be that it's something a collaborator needs to handle, and so you pass it on to them and then you make sure you two are working together to see that this is solved for the patient. So in homelessness, in addition to the things that we mentioned in class, would be sort of like supporting the patient emotionally. If they aren't opening up, to try to get them to open up so we can better meet their needs. If there's a certain fear, worry, or problem that they really are having, in addition to being homeless. I mean, that's bad enough, I can imagine. So that's one example. Medical diagnoses we talked about. So yes, they're medical diagnoses. The physician is going to actually treat those or give us orders to help and assist in the treatment and management of those diseases. However, you have to think about other components of it. So if the physician orders a diagnostic test, for instance, he's not going to add for you or write for you to educate the patient on it. But there is going to be expected that in your scope of practice, you will tell the patient about the test, you'll provide information consistent with their learning style, and you will document that it was done and whether or not they understood it. It could be something as simple as teaching the patient incentive spirometry post-surgery. You have to put down record all of the things that you did and whether or not the patient can return, demonstrate, and things like that. So Don't get too caught up in that. Just understand that, or don't get confused by it, is what I'm trying to say there. Just realize that there are many different problems that do not fit into NANDA. And that has evolved a lot over time, but we still need to include them. So some of the examples on concept maps too would be, let's just say, patient, I don't know, suddenly becomes confused. There's a new onset of something. Well, yes, you're going to tell the physician about it, but in the meantime, you think to yourself, you make quick associations. Okay, patient's all of a sudden confused. I need to find out what it's from. So certainly I want to do a neuro assessment. Certainly I want to make sure they're a fall risk and that somebody is sort of sitting with them till we get things squared away, like what's happening with the patient. Depending on the diagnosis, we may be doing something like blood gases. We might be doing some lab testing, some lots of different pieces of things, part of which are going to come from the physician and part of which we're going to enact. But within it, we constantly go back in and reassess the patient, maybe get repeat vital signs, and that we know for a fact that that person is staying at least where they're at and not decompensating at any point in time. So that's just another way to think of those nursing actions. So, how do we format these nursing diagnoses? Well, it's nothing more than a linear concept map. And it's really a powerful, impactful statement because within that statement are rationales that tell us and that they help us to learn so much, okay? Because remember, as we talked about, examples, rationales. If you don't use those to connect your thoughts, you can't really pass higher than the lower level of Bloom's taxonomy. You can't apply something that you're not making a relationship with. So when we formula nursing diagnoses, we take the problem or concern, whatever it is. Then we're going to add in the etiology or the origin of it. And then we're going to add defining characteristics, which could be subjective and objective. And so we end up with a phrase similar to, I have to recall from class, it was like fall risk, okay, secondary to generalized weakness as manifested by inability to stand independently and need for help with ADLs. You know, that could be something simple, and that would depend on your patient. So in your mind, you're thinking this, and somewhere in the record, you're going to be recording all of this and making a plan. Because certainly that generalized weakness will now impact fall risk. It may impact a patient's ability to eat. It may impact their ability to progress that they can even live alone again at home. So it gets tailored to the patient needs. When we talk about the nursing process, okay, we are going to have many case studies there in the lecture that we can put some of this together. But because a lot of this is new and you haven't had some of this theory yet, it's a place to start. And none of it should be that foreign if you are looking at the material. Okay, so please, you need to be doing that as, for your own responsibility. Now, so once we have these problems and we know we have to intervene on them, that's where these intervention classifications come from. So really all the intervention classifications tell us is that, we need to think in active terms. So whatever we find with the patient that we think is a problem, and it could be something as minimal as the patient has like a little bit of a temperature, to the fact that the patient just fell out of bed and cracked their head on the floor. Okay, we want to make sure we're taking an action. So maybe with the temp, if it's not that high, and the patient just had surgery and we expect it, we won't do anything more than record it and go back later and independently all do all this and then reassess it. So, but if, let's just say you take the temp and it was normal and now it's 101 2 hours later and the patient is in for pneumonia, that tells you that, okay, I know maybe the patient's going to be treated and get some medications, but that temperature spike is really high and kind of fast. So maybe we want to do, talk to the physician. We want to, if there's Tylenol ordered and so forth, and those things will come out more in Nursing 209. But that's how we think of Nick. So whenever you think of a patient concern, you think of two other things. Okay, you think about your nursing interventions and you think about considering the outcomes, because that is sort of an endless cycle, and those outcomes can help identify your next actions, subsequent actions. And then knock, as I said, those are the outcomes. So we talk that sometimes they almost have two phases to them. So when a person is first admitted and we identify a problem, we'll go back to the generalized weakness. We want to establish an outcome where that patient becomes stronger, and we might say becomes stronger and can complete ADLs independently, or patient responds positively to treatment and is able to ambulate with minimal assist. Because at this point, maybe the whole plan of care isn't clear to us yet, based on what we don't know or what is happening still with the patient as they're changing, right? And they're evolving. Then we get to actual outcomes. But you need to think of that as patient focused and write things like that, like patient will ambulate with minimal assist and room in and hallway. Those are just some little examples. So go to see what your book says in addition to that. But that's basically it in a nutshell. And then in the summary, we have to always know that knowledge and judgment is needed to recognize problems and concerns. Right now, we're at a point where you have not had a lot of deep theory. I mean, you know some things from your past sciences, and you're learning things about assessment all the time. So go back to your assessment that you're learning. That should tell you that it's not just about performing the head-to-toe assessment and completing all the components in it, but as you're going down through that assessment, when you come upon something abnormal, you're going to say, okay, what should I be doing about that? You may not be at that point yet, and that's okay. We're growing into this as we learn more about the roles of nursing. So, and then the problems always are going to include Maslow in some way, shape, or form. It may not exactly say Maslow on any nursing form, but when you talk about self-esteem and the physiologic pieces, if somebody is depressed and that's part of their affecting a Maslow phase, that's going to be added too. And then finally, all of these things, the independent nursing actions, use the CUSA knowledge, skills, and attitudes. They become part of the plan of care. So as you go through, go back to, I'm pretty sure the CUSA and KSAs and competencies are posted. Take a look at them to get another idea of how this all comes together. So under teamwork and collaboration, for instance, it'll tell you there's a whole list of the things that go under knowledge, a whole list that go under the skills, and a whole list that go under the attitudes. That helps us put it together with what type of actions we might want to take, both individually as the nurse and then collaboratively as a team. Okay, so we're building a lot of knowledge quickly, but you guys can handle this because this is something we've talked about before. So please make sure to complete your worksheet for next time. And if a mini review of some sort would be helpful, then give me some feedback on that so we can do that. And we can just take it from there.